So a bit on osteoarthritis, because I think that's where MSK intervention that's done by interventional radiology is going to head in the future. But in this talk, we'll cover a few other areas as well. So just an introduction to osteoarthritis. So as we know, it's one of the biggest causes of pain and disability in the UK, and almost 9 million people are affected by this condition in some form. In any joint. The knee is the most common joint where osteoarthritis happens. The four common features that we usually talk about are joint space narrowing, and that's the earliest feature of osteoarthritis that you see. So on this picture, you can see the space between the tibia and the femur is less than it should be. So normally it should be wider than that. And that's the earliest sign of osteoarthritis, but it's not very specific because lots of people have a bit of joint space narrowing. So you can't call everyone with just a little bit of joint space narrowing as osteoarthritic, but it is one of the early changes. You also get subchondral pathology. So under the cartilage, you get either cyst formation, so areas of low attenuation, or you get subchondral sclerosis, which is it appears whiter than it should be. So both of those are, again, signs of osteoarthritis. And then you also get osteophytes, which are extra bony growths on the side of the bone. So normally the bone should have very nice contours, but you might get extra spikes of bone because of disorganized bone remodeling, and that's another feature of osteoarthritis. So those four are the kind of classic X-ray features that you might get in exams or ones you kind of read about in textbooks. MRI, again, the features are similar, but we don't often do MRI for osteoarthritis. It's only in very, very specific cases, like, say, for example, someone's presenting with joint pain and you're not really sure what it is. You might do an MRI for another reason than just find osteoarthritis. So, but the mainstay of diagnosis is the X-ray. So that's typically what we do. So in terms of management, this is going to get a bit boring during the whole lecture, but the management of osteoarthritis is pretty, well, there's not many options, to be honest. So to start with, you manage the weight because that reduces the, dietary factors and other stuff are important as well. Like, you've got to control your diet, not just because of the weight per se, but there's probably a causal link that we're not 100% sure. Function is really important, right? So not just pain, but having good function of the knee joint. Exercises are really, really important for that. So it's important that patients have a physio. So physio is really important so they can strengthen their muscles, and that again promotes function of the knee joint. And then you manage the pain itself. To start with, you start with topical NSAIDs. So the reason why NSAIDs work more than paracetamol is actually we think osteoarthritis is more inflammatory than it once was. So traditionally, it's been taught that it's just simple wear and tear, but latest research is showing that that's not the case, and there is a component of inflammation. And so we're finding that the non-steroidal anti-inflammatories work better than, say, paracetamol for that reason. So topical NSAIDs kind of start with that. Moving on to oral, over-the-counter analgesia that you get. The next step up from that is giving medications into the joint. So colloquially, this is referred to as a joint injection. What you do is you can inject a different bunch of medications. For example, you can enjoy steroids, or sometimes you can inject local anesthetic, but I think steroid is being used for osteoarthritis. They give good short-term relief, but they're not suitable in the long run, because if you keep giving the knee joint steroids, that can impair healing and cause issues. So that's not a long-term solution. It's more of a short-term thing to just get temporary control of pain. Any chronic pain state, there's a big psychological element to that as well, and that's not something you can neglect. So you have to manage the patient expectations and make sure that you're doing your best with the communication and making sure all of the biosocial factors are accounted for, because ultimately, chronic pain is very complex and we still don't know a lot about it, and so it requires a multifaceted approach rather than just throwing medications at it. So that's kind of something important to bear in mind. Especially for older people, you should think that if you're giving them an NSAID, you might need to give gastric protection as well, because it increases the risk of bleeding from gastric ulcers. So consider giving PPI as well for these patients if they're going to be on long-term NSAIDs. If the osteoarthritis is really, really bad, you've got end-stage osteoarthritis and your joint is really deformed, then you'd be a candidate for joint replacement. And so that's kind of the main management options. And so I think that really highlights this treatment gap. So a lot of patients just don't respond to the traditional, I guess you can say conservative or medical management. They're kind of stuck in the middle because they've run out of options. You can't give steroids forever because they have risks associated with them. In addition to that, if you think about the waiting times, at least in the UK and the NHS, they're very, very long. Like, even to see an orthopedic surgeon, they might take a year. And on top of that, work up for, joint replacement therapy. It's a very long time. So, if the patients are not responding to traditional medications and they're waiting for surgery, there's a big gap. There's a big unmet need. Given that osteoarthritis is such a common condition, I think it's been a hot topic for potential new therapies to develop. And so I'll be moving on to that. As we said before previously, radiology involvement in the treatment of this disease has been steroid injections or injecting any kind of drug, because that's done under ultrasound guidance. It's not exclusively done by radiologists, but it's mostly radiologists who are doing this procedure. But in terms of meeting this unmet need for patients who don't have any other options, two kind of options have emerged. And I think the most promising one is genicular artery embolization, but also nerve ablation is something that has cropped up. Yeah, so as I mentioned, intra-articular injections or injections into the joint are kind of an established radiology treatment for osteoarthritis. So what that involves is using the ultrasound probe to scan over the joint and locate the joint, and then just pass a needle close to that and injecting the medication there. Previously, this used to be done blind, but ultrasound has increased the accuracy of delivery of medication, because often if you go blind, you don't actually know if you're hitting the joint. Sometimes it does work because, if you put it near the joint, it's near enough and the drug diffuses, but for the more accurate drug delivery, it's important that you use ultrasound. And I think now most joint injections are done under ultrasound. So what you usually do is you find the suprapatellar recess. So it's a kind of area of joint fluid just above where you'd expect the joint to be, and you inject it into there because that is in communication with the joint. Sometimes it can be hard to see the joint itself unless there is an effusion, because if there's a joint effusion, it's a bit bigger and you can hit the target a bit easier. And that's why it's a suprapatellar recess that's usually targeted. As I mentioned, it gives good or decent short-term pain relief, but you can't use it long-term because of the risk of damage to the cartilage and impairment of the healing process. Platelet-rich plasma is another thing you can inject into the joint. So you basically take the patient's own blood and extract the bit that's rich in platelets. And apparently that's meant to promote healing. I don't know exactly how that works, but that's another kind of potential therapy that has been trialed in some patients in osteoarthritis. So as we mentioned, osteoarthritis is a lot more inflammatory than we once thought. And so there's some early or preclinical studies that show that osteoarthritis is actually quite a hypervascular state. And the disease process comes with neovascularizations and new abnormal blood vessels forming. And so this is a potential therapy target, because if the patients who have a problem all have this problematic vessels, you can target those and then leave the main vessels intact. And it just allows more precise treatment as a general principle. And so this is the kind of preclinical thinking behind genicular artery embolization. And so if you take these patients to angiography, so what that means is you put a catheter into the vessels and inject contrast, and it's kind of the mainstay of what you do in interventional radiology, you'll see that there is hyperemia or excessive blood flow in those areas. So on this image there, you can see on the left-hand image, the normal vessels are just straight lines, but you can see the smudged appearance on the kind of lateral aspect of the knee. That's all neovascularization, and that's not normal. Normal joints shouldn't do that. So that's kind of the pathology or pathological correlate of osteoarthritis. Genicular artery embolization is not a new procedure. It already happens. Like if someone bleeds a lot after a knee replacement, they do this procedure to stop the bleeding. So it's not like it's a completely new crazy procedure. We always do it for bleeding. But this is a new indication because we've seen that there are abnormal vessels to target. And so what you do is you go into the arteries and you inject particles to block off these vessels, but keeping the main vessels intact. And that's how you do the procedure. And it's still relatively early, but the evidence is positive for pain control. The recent study that has shown that even after 2 years, a lot of patients still have good pain control. Not everyone, but the majority of patients do. And so it's a very promising kind of area or potential new therapy. And I thought I'd use this opportunity to talk about what embolization actually is. Some of you might have seen it in your, say, foundation placements or heard of it as a medical student, but it seems a bit weird, doesn't it? Like, why would you block off a vessel? But that's what embolization is. It's blocking off a vessel for a particular therapeutic reason. The well-established indications for embolization is bleeding. So say, for example, a patient's dropping the hemoglobin and on CT scan you see active bleeding, that is a target for embolization. So what you can do is block off that bleeding blood vessel and stop the bleeding. In condition or benign or chronic conditions that are hypervascular, so for example, fibroids, you can block off the blood supply to the fibroids and shrink it and improve symptoms. So it's very well established for fibroid and also now for prostate. So enlarged prostates shrink very well with prostate artery embolization. So those are kind of the main reasons why you would do embolization that are very well established. So then the question is, right, you want to block off this vessel. How do you actually do that? You know, there's so many different agents you can use to block off a blood vessel. I think talking about all of them is way beyond the scope of this lecture, but ultimately you've got two main things. You've got some that are temporary, so you put them in, they stop the blood flow, and then the body resorbs them after a certain period of time, and then that's gone again. And that's usually used for, say, emergency. In some emergency cases, you might use that because you don't need permanent occlusion of the vessel. Whereas a lot of the others are permanent. Say, for example, you're doing a fibroid embolization. You can't put something that's temporary because you won't have solved the problem. So a fibroid embolization will definitely need a permanent embolic. Otherwise, the patient's symptoms are just going to come back. So, you know, broadly speaking, they can be split into temporary and permanent blocks. And the other one is more to do with the technique, but when you inject, some blocking agents stay exactly where you inject, whereas some are more liquid. And when you inject, it flows distally into the small vessels. So those are just different ways in which you can inject embolic material for the reason you want to. And the overall aim of this, generally speaking, is to reduce the perfusion pressure. So if someone's bleeding a lot, you reduce the perfusion enough so that it becomes a trickle, and then slow flow blood will clot because the body will clot it. That's Burkow's triad. So that's how the bleeding completely stops. Now, obviously, the risk is if you completely close off a vessel, it might cause downstream ischemia. That is a risk of embolization always, and so we kind of use techniques to avoid it. And you know exactly how that happens is again very, very complicated. But generally speaking, the aim is to occlude it enough for the indication you need, but you don't want to completely close everything off because of the risk of ischemia, and it's just getting that balance. So generally speaking, those are the principles of embolization. So in terms of how that applies to the genicular arteries, so the genicular arteries, there's 6 in total, but they come off the common femoral artery generally. And they're very small arteries, but because they come off the common femoral, if you can access the common femoral, you can navigate a wire and a catheter into them in order to do the embolization. And how generally we get into the vascular system is through the Seldinger technique. So how that works is initially get a needle and put it into the artery under ultrasound guidance. And that's where kind of the imaging comes in. In the past, people used to do it blind, and some people still do, just, you know, feel where the femoral artery is and then hit it. But complications do reduce if you use ultrasound. And so now the majority of access is image guided. Once you have a needle into the artery, you then put a guide wire through that needle, and that maintains your access so that you don't lose it. Get rid of the needle because you don't want something sharp stuck in there for a long time. And then over that wire, you put a sheath, which is basically like a cannula, but it has a hemostatic valve at the end to prevent backflow from, it prevents blood backflowing, but you can still put stuff in. But it's essentially a fancy cannula. Then that's it. You have access into the vessel, so then you can put like various devices or anything in there to get to where you want to go. So when you've secured your access, you then put a wire and a catheter to try and get into the arteries, and that's pretty much it. I mean, it sounds very simple, doesn't it? But in principle, it is very simple. You know, it's not rocket science. You obviously have to know your anatomy and know the imaging in order to do that safely. But that's kind of the principle of how you do a genicular artery embolism. So I thought I'd also talk about nerve blocks because, again, genicular nerve ablation or block is also a technique you can use to treat osteoarthritis pain. So you can block any nerve you want. You know, any nerve, if you can access it, you can block it in order to reduce pain. And you know, that's done in a lot of indications, not just knee pain. Historically, what you do is you'd use your understanding of anatomy, use surface landmarks, and then basically use a nerve stimulator to see where the nerve is. That seems a bit old school now that we have really good ultrasound that can image nerves, but that's historically how it's done and how technology has evolved through time. And what the aim is once you're there, you can either inject a drug. What you do is you inject either local anesthetic or steroid or something near the nerve, but not directly in it. Because if you inject local anesthetic right into the nerve, it can block action potentials and is neurotoxic. So you want it to be nearby and it kind of just diffuses then. Alternatively, for ablation, it's the same process of localizing the nerve, but instead of going in with a needle and injecting a drug, what you do is you go in with a radiofrequency electrode and effectively burn or ablate the nerve. And so genicular nerve block is that. There's four main nerves supplying the knee. And you basically use ultrasound, use your knowledge of the landmarks to where it is, and then you just go and either inject it with a long-acting local anesthetic, or you can go in with a radiofrequency ablation and ablate the nerves. So that's kind of an introduction into nerve blocks, and not just radiologists that do that. I think anaesthetists probably do the most nerve blocks because it's usually done for pain relief and surgery. So that's going to be with a bit more of a shorter acting agent. The anaesthetists are kind of masters of nerve blocks, but for chronic pain, you can also do it. Radiologists can also do that, and some certainly do. Inflammatory MSK conditions represents a very large group of conditions, all of which involve inflammation of an MSK structure. So we've already talked about joints, and osteoarthritis is a bit more inflammatory than we once thought. But say if it's the capsule, it's called capsulitis. If it's a bursa, so an extension of the joint fluid near the joint, that's bursitis. And if it's tendon, it's tendonitis. So any MSK structure can be inflamed. Each of them have their own name, but we kind of group them under inflammatory MSK conditions because their management is pretty kind of similar. The ones I'll talk about that I'll mention as examples are Achilles tendinopathy, adhesive capsulitis, and I don't think I will talk about condylitis, but kind of mention adhesive capsulitis. So we'll move on to that. You might know it as frozen shoulder, but actually what it is the joint capsule of the shoulder gets inflamed. And with that inflammation, eventually it contracts and that becomes really painful. And so the shoulder can feel really stiff. Patients might not be able to move it, not just in one direction, but all directions. And so if someone presents with chronic pain and stiffness and you can't pinpoint a particular movement, it's just globally reduced, you should always think, oh, do they have frozen shoulder or adhesive capsulitis? The main risk factor, particularly in medical exams, is diabetes. So always be aware of that middle-aged person's shoulder pain and diabetes is adhesive capsulitis until proven otherwise. Now, here the imaging is really important because not to make the diagnosis, but to rule out other pathologies, because shoulder is very, very tricky. So you always get an X-ray because you want to make sure that it's not osteoarthritis that's driving this pain, but also you want an ultrasound because ultrasound is pretty good at looking at the rotator cuff, and you want to make sure you haven't missed like a supraspinatus tear or something like that, because all of them can present with a bit of shoulder pain, a bit of movement problems. So imaging is very, very important because you want to get the diagnosis right, and the treatment and even the physio regimen are all different. So imaging is very, very important in the shoulder, whereas perhaps it's not quite as important, say, for knee osteoarthritis. Management, again, the first bit of management is pretty much the same as osteoarthritis. So physio, pain medications. Occasionally you can do steroids to control pain temporarily, but not for long term. But it's the other kind of more advanced options that differ and are a bit more interesting. So hydrodilation is when they basically just inject stuff into the joint and widen that joint space. I'm not sure on the evidence of that, but it is a kind of new treatment. Nerve blocks we've already talked about. So in this case, it's the suprascapular nerve that supplies the glenohumeral joint. And so similar to we talked about genicular nerve block or genicular nerve ablation, same principle. Use your landmarks, find the nerve, block it. So as you'll see, it'll probably get really boring towards the end of it because all the management is pretty similar. And arterial embolization, again, we talked about GAE. There's people doing this in shoulders as well. And of course, the surgical option is arthroscopy, where you release the capsule. So I'll talk a bit about embolization. So as mentioned, anything that's vascular and has abnormal vessels are potential targets for embolization. Adhesive capsulitis, like osteoarthritis, also shows changes on angiography. So what you can do is you can go in and find these abnormal arteries and just embolize those ones and leave the main ones. And that's really, really important because you don't want to cut off the blood supply to vital structures in the shoulder or even down the arm. So that's typically how we go. And for the shoulder, how you get it is you don't go through the leg, you'll go through the wrist. So radial access, or accessing the radial artery for a procedure, is being done increasingly for IR procedures, but it's much easier to access the shoulder because it's just a straight line, whereas going through the groin has more bend and it's a bit more of a windy course, so you'd rather not take that if you can. So I thought I'd talk about radial access and just kind of explain the principle of it. The first thing you have to do is make sure that they have good collateral circulation, so the ulna. The radial and ulnar arteries form an arch in the arm, or in the hand, sorry, but what you want to check is that if you were to occlude the radial artery, which is always a problem when you're putting something in there, is there really a high chance of ischemia? And in the past, you might have heard of Allen's test before you do an arterial blood gas. That's what we used to do, but we do something different called Barbeau's test, where you occlude them when you check collateral circulation. But the principle is, as is anything in IR, if you do something and cause a complication, how bad is it, and is it worth the risk? Because everything is risk benefit. So that's why you're doing it here. And under ultrasound, you also measure how big the radial artery is, because you need to make sure that the instruments you put in don't completely occlude the vessel. So you still need to flow around it. And different equipment has different size requirements. Again, I'm not going to talk about all of that, but that's kind of the principle. Getting into the artery is exactly the same as a femoral in the first instance. So Seldinger technique, needle, wire, get the sheath in. The only difference is your radial artery is very small and it can spasm, and that's what you ideally don't want. So usually you give a bunch of drugs into there to try and prevent spasms and muscle contraction of the arteries. So you tend to give a cocktail of 3 drugs of calcium channel blocker, GTN, which is a vasodilator, and heparin, which is anticoagulant, to try and reduce blood clots. And that kind of is called a radial cocktail sometimes. You just mix it in a syringe and inject it slowly, because otherwise it could, patients can experience stinging as you inject it. So the whole reason for that is let's try and prevent vasospasm, which is obviously not ideal. It doesn't apply in the case of shoulder, but generally when you go radial, you have to go into the aortic arch. And anytime you pass wires through the aortic arch, there is a small risk of stroke. I don't know exactly what it is, but that's always something you consent patients for when you go radial access for the body. In this case, you're not going far enough, right? You're stopping at the shoulder, so that risk isn't there. But as general access for radial artery procedures, that is a thing that you consent patients for. And you do the procedure, and then when you want to close the radial artery, they use something called a compression band. So it's just to provide pressure, and they release it slowly. It just saves you having to push for so long. So that's kind of what you do in order to put pressure on the vessel and stop any bleeding when you take the stuff out. So we'll move on to the next one, which is Achilles tendinopathy, which is another emerging target for interventional radiology. Again, closing the name, the Achilles tendon inflames, and that presents with pain and stiffness. And it's a clinical diagnosis. Patients will complain of heel pain, and they'll have tenderness in that tendon. The main thing we want to exclude is tendon rupture. So especially if a patient has an acute onset of history, or say they're on a quinolone antibiotic, which is a classic association for exams, those should prompt thinking of tendon rupture. You scan the tendon and make sure there's no break in it, and that's what you do for excluding tendon rupture. Again, you can also get in, not always that great. In terms of treatment for Achilles tendinopathy, again, at the start, it's exactly a short course of pain relief, physiotherapy, and exercise is the key. There's a shockwave therapy that you can do for Achilles tendon. That's, again, a kind of newer treatment. I don't know too much about it. MSK embolization treatment. It seems to work very well for Achilles tendinopathy. Thanks to the world to try and, improve the management of MSK conditions that, again, potential treatment for where radiology has a role with back pain. So back pain is really common. I mean, like 80% of adults will experience it at some point in their life. So it's a huge quality of life problem, similar in scale to knee osteoarthritis. Now, as you kind of probably aware from either medical school exams or clerking in ED, patients who present with acute back pain, you want to rule out emergencies. And the 3 main things we worry about are caudoequino compression, so compression of the roots, the lumbar roots or below, metastatic cord compression, so from cancer, or an abscess. And if you look at patients who present with back pain to GPs, they resolve within 4 to 6 weeks in the vast majority of patients. So most patients will come in, they'll have red flags excluded, and they'll just have conservative management for 4 to 6 weeks. But Persistent back pain is a major cause of disability. So chronic really is 3 months or more as a definition, but that's kind of where you call it chronic back pain, and very, very tricky to solve because, again, initially it's pain management, physiotherapy, but there's not options, and radiology is involved in some of the non-surgical options for these patients. You've probably heard about either nerve blocks, they're called epidural blocks, or facet joint blocks, so injections into the facet joints and the joints between the vertebra. Those are two of the main things where radiology has an input in patients with chronic back pain. Next slide, we'll talk about injections into the nerve root. So epidural injections. So epidural is just the space outside the dura. So the brain and spinal cord have 3 layers, and the dura is the outermost layer. And between bone and dura, there's a bit of fat and a potential space. So that is the space where you aim to inject with anything that you give. So these are generally done for sciatica, so back pain that's in a dermatomal distribution. And you've got 2 options really. One, you can inject the epidural space close to the midline. So in this picture, it's arrow B. So just parallel to the spinous process, you get into the epidural space and you inject your drug there. And the benefit of that is it spreads out across multi-levels. So someone who's just got describing multi-level sciatica on one side, that would be a great target for it, right? Because you put it in, it might spread over a couple of levels, probably the way to go. What you could do instead is you can inject a nerve root, which is a slightly different position. So that's trajectory A on that picture. Those patients you might give if there's symptoms related to one nerve root. And the benefit of that is you're giving a whole drug at one root. And so that's just a more concentrated injection that might work better. And how it's done is you just use x-rays. So you use your knowledge of anatomy and your physical landmarks to plan your needle trajectory. So if you look on that picture there, like on the right, there's all the anatomy overlaid on it. But if you know your anatomy, you can figure out the needle trajectory, and you can rotate the X-ray up different ways to see. And there are lots of causes of increased pressure. So, for example, if you have other carpal tunnel structures, so it's something that occupies space within it. Say you've got less space for the nerve, and so that impinges on it. And otherwise, systemic inflammatory conditions, all of those patients can get carpal tunnel because it's inflamed and bigger. And not that all fully understood, it's probably the right word, but effectively you get symptoms because there is increased pressure on the median nerve. But yeah, some of these risk factors are listed as a pregnancy, again, is a classic association. Don't exactly know why that is, but yeah, the mechanism is unknown. Again, in terms of management, so what you initially do is you put someone in a wrist splint. So if you put someone in a neutral wrist position, that seems to be the lowest amount of pressure in the carpal tunnel. So it's fixed in that position for a bit. Again, you can give steroid injections. In the past, the mainstay was surgery, so it's a big scar and a big operation. But more recently, there's a technique developed that is ultrasound guided release. It's theoretically very simple. Obviously, there are lots of important structures to the carpal tunnel, so it's technically a difficult procedure because you have to make sure you're safe. But the principle is very simple. You use ultrasound and get a view of the carpal tunnel. You inject local anesthetic, and then you create a little bit of space under the flexor retinaculum, and then you put a hook device in to basically release it. So it's a hook that you put under, but it's got a hook on the back. So as you drag it through, it makes a kind of micro incision in the flexor retinaculum, and so that releases pressure in the carpal tunnel and will reduce carpal tunnel syndrome, or symptoms rather. So that's again a new kind of radiology-led technique where you can do something without invasive surgery. And I think in a lot of cases, interventional radiology fills that gap. Like patients who you've got medical management here and you've got surgical management there, but there's this middle group which is intentional or minimally invasive, whatever word you want to call it. And a lot of that is driven by radiology. So hopefully that's kind of the common theme here, that these patients have failed medical management, can't have surgery. Their only option is something minimally invasive through the radiology department. So move on to oncology. Again, MSK interventions have a big role in oncology patients who have MSK problems. The main things you kind of see are like biopsy. So most biopsies now are done by radiologists. Gone are the days of surgical biopsies in the majority of cases. Usually we can get to it by some kind of imaging, whether that's ultrasound or CT. Preoperative tumor embolization's another kind of technique that helps with tumor surgery. Ablation is really game changing. I think, especially in renal cell carcinoma, not for MSK per se, it's just as good as a partial nephrectomy. So these are all minimally invasive things, and then palliative care has an important role as well. So next slide, we'll talk about bone biopsy. So all that means is if you've got a solid lesion within the bone, you take a sample of it, and that's different to a bone marrow trophine or aspirate that you do on hematology, in that you are targeting a specific lesion rather than just getting into the marrow and taking cells. So that's kind of what you mean when you say bone biopsy. It's not always done for cancer, actually. Sometimes if you have an MR and you're really not sure what you're looking at, you might just biopsy it. So we've had some cases where there's osteomyelitis, but you're not 100% sure on the MR. It could be anything. So sometimes you just have to biopsy it and send it to the lab and maybe for a culture to get an answer. So there are conditions where, there are situations where it's not necessarily malignancy, but you just need to get a biopsy to figure out what's going on. And generally speaking, it's CT guided. I mean, CT is a great modality to look inside the bone. Like, you can see the cortex and the medulla and then any lesions in it. So that's predominantly what is there. Ultrasound generally is not good for looking at normal bones, but if you have soft tissue within a normal bone, then you might see it on ultrasound. So say, for example, you have a very superficial rib lesion, you might just ultrasound that rather than CT because it's right on the chest wall and you can get to it. And sometimes fluoroscopy is used. Generally speaking, we use a coaxial technique. So what that means, it's a specific way of doing it. You put a hollow needle into the lesion and then keep it. So when you put your biopsy device in, rather than having to get into the lesion again and again, you've got stable access into the lesion that you can just keep going in and out and grabbing as much tissue as you need. So a lot of biopsies, at least deep ones, are done with a coaxial technique because it's going to be really annoying to keep getting back into it. I thought I'd explain a little bit about biopsies in general. So again, as I said, radiology performs a vast majority of biopsies. In terms of devices, there are two main ones you can use. So there's one called the biped. These are trade names, but I'm not even sure what the non-trade name is, but biopsy is a device that you put a needle into the lesion and it fires forwards. You actually get a better sample, but it's a bit harder to control. And, sometimes, especially with ultrasound, you might not see exactly what's beyond the lesion. So it's a bit riskier in that it's a bit harder to control, but the samples are better. Whereas with a 10 mode device, what you do is you advance a tray and then cut over it. So if you look at the top left image there, picture A is what you do. You park the end of the device just in front of the lesion. You then advance a tray, so you know exactly where the end of that tray is, and then the bit before the tray is the tissue that you grab. So you're a bit more secure in exactly where you're taking the tissue from, but at the cost of a lower quality sample. And so different radiologists have different views, but different preferences and what they take. And of course, bone, you can't just penetrate with that. You need a drill. So there's a specific device for bone biopsies, but tissue. So next slide, we'll talk about pre-op tumor embolization, and that's an important role for interventional radiology. So as I keep mentioning, and probably getting bored of this, hypervascular things are great targets for embolization. And lots of cancers are hypervascular. I mean, as they grow, they have neoangiogenesis in new blood vessels. Not all tumors are hypervascular, but some definitely are. Chopping them out will cause a lot of bleeding. Sarcomas in particular are actually quite vascular and they're difficult operations. So we've recently done a couple of cases where we did a pre-op embolization for a sarcoma, and those normally have liters and liters of blood loss, but because of an embolization, it basically didn't bleed. So it really makes the surgery a lot less. The morbidity from surgery is a lot less, mortality as well. So there's one series that's published in MSK tumors that 70% had bloodless surgery, which is, these are big operations, which is quite important. And it's one of those procedures you can do that does make a big difference to outcome anyway. So there's going to be an increasing role for pre-op tumor embolization as we go forward. So pain control in bone mets is another area where interventional radiology helps in MSK conditions. Bone mets often cause a lot of pain. The cortex is very, very sensitive, and so what you can do is traditionally you could do radiotherapy, but another option is ablation. So what you do is you go in and destroy the tumor cells, and somehow that improves pain. And I'm sure there's a complicated reason why that is, but also if you've got metastases in the vertebra, not only can they cause pain, but they can cause vertebral like collapse and compression fractures. So ablation effectively is destroying the tissue by depositing some kind of energy. And the aim is to cover the whole lesion and also have a safe margin for the small kind of micro disease that might be surrounding it. There are different types available. So the original one was radio frequency ablation, which is a heat-based technique. So you literally, there's no other science, so you just heat it up and burn the tumor. There's a slightly improved heating thing called microwave. It gets rid of some of the technical issues with RFA, but it's not as well studied way to do it. You can also freeze it, so there's something called cryoablation, and I think that has the best outcome in renal cell cancer. The newest technique is IRE, or irreversible electroporation, and that you basically put in current, and that breaks pores in the cell membrane and induces apoptosis. You're basically electrocuting the cells. So they're all different methods of depositing some kind of energy within the cells or within the tumor to kill it off, basically. I think we've covered a few, or given an introduction to a few MSK interventions and a wide range of conditions. They employ kind of the whole gamut of interventional techniques. So we talked about biopsies and ultrasound guided targeting, ablation and embolization, and these are core techniques to interventional radiology. They're all used within the MSK space. It's great to see that actually a wide range of pathology or wide range of uses. Next slide. I thought I'd just include this as a final slide. So most MSK intervention in the UK, at least, is done by MSK radiologists. So they do the vast majority of joint injections and bone biopsies, although some interventional radiologists do them. The ones that involve blood vessels, so embolization, vascular stuff, that's usually done by interventional radiology. So they have the most experience in vascular access. So, like almost a lot of procedures that are done by IR, like traditional IR, if you want to call it that, are vascular based. And so, they're the best at accessing vessels to do MSK work. So that's a lot of the embolization stuff is being driven by, if you want to call them vascular interventional radiologists. I think the summary of it is there's no clear-cut boundaries. And say, for example, you like doing IR, but also want to do some MSK, you can do that. And, the career paths as a radiologist are quite varied. You can almost make it what you like. So that's just something to bear in mind as well. The role of embolization as well, in particular, I think will increase. GAE there's a lot of fast-moving trials that are underway, and so hopefully that adds to the body of evidence for that. But I think that's the kind of next frontier in MSK intervention. So that's it from me. Thanks all for listening. If you want to find out more about any of this stuff, when you're on your either student selected modules or on your taster weeks, you should visit your MSK and your interventional radiology department.